Well, good morning, everyone. It's a real pleasure to be here, and I certainly want to send my congratulations and my thanks to Kyle and to Sang for putting a really wonderful symposium here. I got to tell you from personal experience, this is a tremendous amount of work, a two-day symposium with, I counted about 45 talks. It's absolutely incredible. It's great to see you guys start out nice and slow here in California. And an invitation to come to Los Angeles is always a very nice thing, certainly. And I enjoy these symposiums because I learn a tremendous amount from my fellow colleagues. But I'm going to talk to you today about laparoscopic total mesocolic excision. What is the current evidence? I don't have any relevant disclosures for this talk. And certainly the impetus behind this is obviously what we all dread in our surgical careers and our day-to-day routines. We all know that there's probably nothing more terrible than a local recurrence in the pelvis after a rectal cancer operation. We know that this is a significant disease state for the patient, severe pain, quality of life, and the demise of this patient with the pelvic recurrence is terrible, and we try to avoid as much as possible. So we understand that certainly from the wonderful work from our European colleagues, particularly Professor Heald and Professor Quirk, elegant studies done back in the 80s and 90s in terms of respecting the appropriate surgical planes in the pelvic area, understanding the anatomy completely in terms of which fascia is involved and which fascial dissection should occur and which avascular plane should be dissected. Till then, again, I think there was not a full understanding of the need for sharp dissection in the pelvic area to really understand the surgical planes and respect those surgical planes. And as Dr. Stamos mentioned, you cannot replace good quality surgery. And particularly when you're dealing with rectal cancer, it's very hard to make up when it's a poorly done operation. And certainly the patient pays the price for that. So when we look at obviously doing a total mesorectal excision or a TME, we understand that the local recurrence is significantly lower, that 5-year survival is increased in those patients when the appropriate operation and dissection is done. And there's no question about that. We have long-term studies from multiple large registries followed up for very long periods of time. So we understand that, again, respecting the